All right, this one we're going to do the 6 ranges of motions. It's still, we're doing the shoulder, okay? So flexion, I'm going to instruct you to raise your arm in front of you and over the head. Okay. Extension, instruct the patient to raise your arms behind you. Just one is fine. And abduction, raise your arms outside and over the head. Okay. And adduction is patient to cross his arm in front of his body. Okay. Now the internal rotation. Okay. Instruct the patient to place one hand behind his back and touch his shoulder blade. Shoulder blade. Able to touch? Okay, good. External rotation. Instruct the patient to raise his arm to shoulder level. So bend the elbow and rotate the forearm toward the ceiling. Good. Or place the hand behind the neck of the head as if he is brushing his hair, but you don't have hair. Patient demonstrated good ranges of motion in both shoulders. All right. The maneuvers for examination of the shoulder. First, we're gonna do is the acromyoclavicular joint, crossover or cross-body adduction test. Adduct the patient's arm across the chest. Adduct means cross your arm in front of your body, and I'm going to assist that so I can feel the resistance too. So that's good. Negative for pain upon adduction and no tenderness noted in the acromyoclavicular joint. All right, this one we're going to do the overall shoulder rotation or applet scratch test. So I'm going to ask you to touch the opposite scapula using 2 motions. One is over and one is under. Okay, I'm going to assist you. Okay, and then under. Do you have any pain?
No.
Okay. So absence of pain during the applet scratch test maneuver. So another maneuver is called the rotator cuff pain provocation test or painful arc test. It's fully abduct the patient's arm from 0 degree to 180 degrees. So for near impingement sign, press on scapula to prevent scapular motion with one hand and raise the patient's arm with the other. This compresses the greater tuberosity of the humerus against the acromion. So we're going to do the fully abduct patient's arm from 0 to 180 degrees. In the near impingement sign, press on the scapula. Okay. Do you have any pain?
No.
Or press the greater tuberosity of the humerus against the acromion. So it's here. Thank you. So the Hawkins impingement sign, flex the patient's shoulder and elbow to 90 degrees with palm facing down. Then with one hand on the forearm and one on the arm, rotate the arm internally. This compress the greater tuberosity against the supraspinatus tendon and coracoacromial ligament. Okay. Okay, now let's do the Hawkins impingement. Okay, good. Do you have any pain?
No.
All right, thank you. So those 2 maneuvers, the near impingement sign and Hawkins impingement sign, is a test 2 for pain in rotator cuff, okay, or painful arc test. And the findings is the patient demonstrated negative shoulder pain in both maneuvers. Okay, this one we're going to do the strength test, internal rotation lag test. So I'm going to ask the patient to place the dorsum of hand on the low back with the elbow flexed to 90 degrees. Then I will lift the hands off the back and we will, which further internally rotates the shoulder, and ask the patient to keep the hand in this position. So I'm going to apply pressure. All right. Patient is able to hold the hand in the instructed position. So this is another strength test, the drop arm test. So I'm gonna ask you to fully abduct the arm to shoulder level. Okay. Up to 90 degrees and lower it slowly. So I'm gonna note for the abduction above the shoulder level from 90 degrees to 120 degrees. Reflex action of the deltoid muscle. Can you repeat it again? Thank you. Do you have any muscle weakness? Okay, this time we're going to do the composite test. The first is external rotation test, resistance test. I'm going to ask the patient to adduct and flex the arm to 90 degrees with the thumbs turned up. Stabilize the elbow with one hand and apply pressure proximal to the patient's wrist as the patient presses the wrist outward in external rotation. Yeah, I think I did it right. So, all right, the other side. Okay. You have any pain?
No.
Okay, so no signs of infraspinatus disorder. Okay, the second composite test is called the empty can test. Elevate the arms to 90 degrees and internally rotate the arms with the thumbs pointing down, as if emptying a can. Ask the patient to resist as you place downward pressure on the arms. Okay. I'm gonna put pressure downward. Okay. All right. Patient is able to hold the arm fully abducted and at the shoulder level and noted with good strength. Okay, this time we're going to examine the elbows. So first I'm going to inspect. So I'm going to support the patient's forearm with the opposite hand so that the elbow is flexed to about 70. Identify the medial and lateral epicondyles and the olecranon process of the ulna and the olecranon process. So I'm gonna do the inspection first. Okay. So here, I think you should position here. Okay. And support the elbows. I'm gonna check for any tenderness. Locate here. Okay. Do you have any pain or any discomfort? Thank you. Okay, so findings for that, absence of nodules and swelling in the elbows. Now I'm going to palpate the olecranon process and press over the epicondyles, which is similar to what I just did. No tenderness. So for the ulnar nerve, it is the sensitive ulnar nerve can be palpated posteriorly between the olecranon process and medial epicondyle. It's in here. Okay. So there is no displacement of the olecranon process noted while I palpated his elbow. So we're gonna do the range of motion and maneuvers this time. So range of motion includes flexion, you can do this, and extension, okay, at the elbow, and the pronation and supination of the forearm, which also move the wrist and hand. So demonstrated good range of motion of the elbows and hands. Okay, Mr. Downing, I'm going to inspect the wrist and hand, beginning at the inspection and the position of your hand in motion for smooth, natural movement. When your fingers are relaxed, they should be slightly flexed, and the fingernail edges should be in parallel. So I'm going to also inspect the palmar and dorsal surfaces of the wrist and hand carefully for swelling over the joints or any signs of trauma. So when you talk, do you use your hand gesture, or you talk your hands down, relax?
I use my hands.
Use your hands. So you just want to look at your wrist. Okay, the palmar. Okay, dorsal. Thank you. So both hands movement are natural. Fingers are slightly flexed, and fingernail edges are in parallel. No swelling noted over the joints and no signs of any trauma. This time I'm going to palpate. Okay, at the wrist, palpate the distal radius and ulna on the lateral and medial surfaces. Palpate the groove of each wrist joint with your thumbs on the dorsum of the wrist, your fingers beneath it. And also, I'm going to palpate the radial styloid bone and the anatomical snuff box. It is a hollow depression just distal to the radial styloid process formed by the abductor and the extensor muscles of the thumb, and the snuff box is more visible with lateral extension of the thumb away from the hand. Abduction. Okay, I'm just going to use this. So radius and ulna. This is the radius and ulna. Okay. And then the radial styloid bone and anatomical snuff box. This is it. Alright, do you have any problem? Okay. Okay, this time I'm going to palpate the 8 carpal bones and MCP joints. Palpate the 8 carpal bones lying distal to the wrist joint, and then each of the 5 metacarpals of the proximal, middle, and distal phalanges. Compress the MCP joints by squeezing the hand from each side between the thumb fingers. Alternatively, use thumb to palpate each MCP joint just distal to and on each side of the extensor tendons as your index finger feels the head of the metacarpal in the palm. Okay. So this is the 8 bones. This is distal. And then compress the MCP joints. Okay. Okay. No problem. So this time we're going to check for the Bouchard's node and DIP or deep joints. Palpate the medial and lateral aspects of each peep joint between your thumb and index finger using the same technique. Examine the deep joint. So he doesn't have Bouchard's, but that I'll just demonstrate it is how you do test it. It's just like on the tip of the finger. Let me see. And you can sometimes you can visibly see if there's the shape of the fingers is not symmetrical, or there's prominent bones, and you can see mostly those kind of fingers for patients with arthritis. Okay, this time we're going to do the range of motion of wrist and hands. So I'm going to instruct the patient with palms down. Point your fingers toward the floor. Extension. Instruct the patient with palms down. Point your fingers toward the ceiling. Okay. Adduction or radial deviation. Instruct the patient with palms down. Bring your fingers towards the midline. Okay. And abduction for the ulnar deviation. Instruct the patients with palms down, bring your fingers away from the midline. Okay, so no arthritis, no tenosynovitis noted, and demonstrated good range of motion. I was so focused. Okay, now we're going to do the sensitivity test. So I'm gonna poke or pulp the index of your finger to test the median nerve, and the 5th finger to test the ulnar nerve, and the dorsal web space of the thumb and index finger for the radial nerve. Okay, this one. feel anything?
I feel.
Okay, and then the web.
Yeah.
Okay, thank you. Noted with good sensation to the index, thick dorsal and dorsal web space. Okay, we're gonna do the hand grip test. So I'm gonna instruct the patient to squeeze my fingers as hard as he can. Ow! Okay, that hurts. Very strong. Okay, this time we're gonna do the thumb function. Ask the patient to grasp the thumb against the palm and then move the wrist toward the midline in the ulnar deviation or the Finkelstein test. Okay, put that in. All right, no pain and no pain. No pain noted this maneuver. Okay, we're gonna do the carpal tunnel syndrome test. Ask the patient to raise the thumb and straight up as I apply downward resistance. All right, do you have any pain?
No.
So findings, no problem noted. Patient able to apply resistance during this maneuver. So this time we're going to demonstrate another test for carpal tunnel syndrome, the Tinel sign. So by tapping lightly over the course of the median nerve in the carpal tunnel. This is very quick. I'll use this one. Have any pain in your... Okay, thank you. So absence of ache and numbness noted in the median nerve. Okay. Now we're gonna do another test for carpal tunnel syndrome is the Phelan sign. So I'm gonna ask the patient to hold the wrist in flexion for 60 seconds with the elbows fully extended. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, and 60. Okay, thank you. So patient is able to flex his wrist at 60 seconds with elbows fully flexed or fully extended without any problem. So this time we're going to examine the spine. Move the camera. So in the inspection, so inspect the patient's posture when entering the room, including the position of both neck and trunk. Assess the patient's for erect position of the head, neck, and back for smooth coordinated neck movement and for ease of gait. So technically in general, it's the posture. Okay, this time we're going to inspect part of the examining the spine, inspect the spinous process. So unfortunately it's cold and I don't want my husband to get sick. So spinous process from a sitting or standing position. Palpate the spinous process of each vertebra with your thumb. So I'm going to demonstrate it. It's here. Okay. And actually I can feel it with this shirt on. Okay, this time we're going to palpate the facet joint. It's in the neck. Okay, palpate the facet joints that lie between the cervical vertebrae 1 to 2 centimeter lateral to the spinous process. Remember, it's here. So it's going to be here. Okay, of C2 to C7. These joints lie deep in the trapezius muscle and may not be palpable unless the neck muscles are relaxed. So try to relax. I will try. See. Yeah, it's different when the patient's neck is stiff and when the patient's neck is relaxed. Okay. I think that's it. Not much, but you can feel the difference. Thank you. Okay, this time I'm going to palpate over the sacroiliac joint often identified by the dimple overlying the posterior superior iliac spine. So it's gonna be here, okay? With him, even with his shorts, I can still feel it. Okay, thank you. All right, this time I'm going to palpate the paravertebral muscles for any tenderness. Okay, it's just somehow lateral to the spinous process. Okay. Here. Okay. No. Now this time we're going to check for sciatic nerve. With the patient's hip flex and the patient's lying on the opposite side, I will palpate the sciatic nerve, which is the largest nerve in the body, consisting of nerve roots from L4, L5, S1, S2, and S3. The sciatic nerve lies midway between the greater trochanter and the ischial tuberosity as it runs through the sciatic notch. It is difficult to palpate though in most patients, but I will demonstrate it where to palpate it. Somewhere here. Okay. Thank you. Okay, now we're going to inspect the neck, which this is a demonstration because we've done this in the previous unit. So I'm going to inspect the neck, including the sternocleidomastoid. Okay. Just look for the symmetry. Okay, right and left. Okay, see this? This is SMC. Okay, this time I'm going to inspect the muscle, muscle examination. I will palpate the spinous processes of the cervical spine, the trapezius muscle, and the muscles between the scapulae. So I'm going to note for any tenderness. That's the trapezius. No tenderness. No tenderness noted. Okay, this time we're going to check the range of motion of the cervical spine. So we're going to do the flexion, extension, rotation, and lateral bending. And if you have any pain, just let me know. Okay, so I'm going to instruct you first for the flexion to bring your chin to your chest. Okay, now for extension, look up at the ceiling. All right. Rotation, look over one shoulder and then the other. Okay. Do you have any pain there?
Some stiffness.
Right or left? Okay.
Left.
Left. Okay. Lateral bending. Bring your ear to your shoulder side, and you feel that a little tender.
Yeah.
Okay, on your left. Okay. So there's a tenderness on his left shoulder, but there's no weaknesses at all.
No.
Okay, no
It's just
weaknesses.
an injury.
Just tender. Okay. Okay, now this time we're going to do the lower spine range of motion. So I will ask my patient here to first is bend forward and try to touch the toes. Okay, now extension, bend back as far as possible. Okay, rotation, instruct the patient to rotate from side to side. Okay, let me know if you have any pain. Okay, and then bend to the side from the waist. No pain. All right, no pain or tenderness during the test of spine range of motion. To the top. Okay, this time we're going to examine the hips. First, inspect the hips. Begin with careful observation upon the patients entering the room. So we're gonna see the gait right away. So for the stance, when the floor is on the ground and bears weight, about 60% of the walking cycle. So try to walk like 5 steps. 2, 3, 4, 5. So for the swing, go back. When the foot moves forward and does not bear weight, that's the swing. Okay, that's the swing. And then walk move forward. So that is 40% of the cycle. Thank you. All right, now we're going to do the bony landmarks. I'm going to palpate the surface landmarks of the hip and the anterior landmarks. So not all, because the pubic tubercle, I don't think so I will be able to demonstrate it here, but I will read this, okay? Anterior landmarks, iliac crest at the upper margin of the pelvis at the level of L4, and follow the downward anterior curve and locate the iliac tubercle, making the widest point of the crest, and continue tracking downward to the anterior superior iliac spine. Okay, so the landmark is here, right? So we would locate the landmark, the bony landmark, and we'll find the iliac tubercle, the iliac crest, okay, and the anterior superior iliac spine. Okay, there it is. And then with my thumb palpating it, I can locate easily, just move a little bit back here, the greater trochanter, and then the pubic tubercle. Okay, this time we're going to locate the posterior superior iliac spine. On the posterior aspect of the hip, palpate the posterior superior iliac spine just above the buttocks. I think that is the easiest landmark. It's here. We actually did it here, so that's where it is. Okay, so the greater trochanter, which I demonstrated earlier, okay, it's here. Okay, moves on the side. It's somewhere here. Yeah. Okay. That's it. Okay, this time we're gonna do the inguinal structures. So since the patient, I asked him to do it, to be in supine position, place the heel of his leg being examined on the opposite knee, then palpate along the inguinal ligament, which extends from the anterior superior iliac spine to the pubic tubercle. So technically it's here. So I just want to demonstrate how you will palpate the inguinal structures. So to remember the lateral medial sequence of navel: nerve, artery, vein, empty space, and lymph node. Thank you. Okay, now if the hip is painful, palpate the psoas persa, below the inguinal ligament, but on a deeper plane. So it's gonna be here. So findings: no tenderness noted, no bulges noted, lymph nodes are not inflamed, and no focal tenderness over the trochanter. Okay, this time we're gonna do the range of motion of the hips. So for the hip flexion, I'm going to place my hand or my arm underneath his lower lumbar section, and I will have to instruct the patient to bend his knee to his chest and pull it against the abdomen. Okay, can you bend your knee to the chest? Okay, thank you. So this time we're going to do the hip extension. I'm going to instruct the patient lie flat, move the lower leg away from the midline and down over the side of the table. Okay. I think I should move the camera. All right. I think that's more visible. Do it. All right, thank you. Okay, this time we're gonna do the hip abduction. So since the patient's lying flat, I'm gonna move the lower leg away from the midline, and my other hand is trying like a control to move the other side of his hip. Hold on. Okay, and I have to feel it. Thank you. So for the hip adduction this time, the patient is lying flat already. Bend his knee and move his lower leg toward the midline. Okay. So same thing as the abduction, but this one is here. All right. Thank you. Okay, we're gonna do the external and internal rotation. So patient lying flat and external first. Bend your knee and turn your leg and foot across the midline, and then I'm gonna guide it. The external, and then this is the internal. Okay, thank you. So finding demonstrated excellent range of motion of the hips. Alright, this time we're going to examine the knees for inspection. Inspect the gait for a smooth rhythmic flow as the patient enters the room. The knee should be extended at heel strike and flex at all other phases of swing and stance, and patient in supine position. Okay. Alright, this time we're going to check the suprapatellar pouch. Okay, to palpate for any thickening or swelling in the suprapatellar pouch and along the margins of the patella. So I'm going to start 10 centimeter above the superior border of the patella. So this is the patella. Okay. Well above the pouch and feel the soft tissues between the thumb and fingers. Move your hand distally in progressively steps, trying to identify the pouch. Continue your palpation along the sides of the patella. So technically just, sorry. My patient has tickles. I forgot. So I'm going to pretend I'm palpating it, but that's where it is.
Okay.
Oh, here, you still tickle. So there's no swelling, there's no tenderness. Okay, wait for the next test. Okay, this time we're gonna palpate the tibiofemoral joint. So the patient knees needs to be flexed and the edge of the tibial plateau and the margins of the joint. So basically it's here. Let me know if you have tickles. Okay. So no tenderness or increase of warmth noted. And no irregular bones ridges. Okay, this time palpate the medial and lateral meniscus. Okay. This is the medial and this is the lateral. I'm not hurting daddy. Okay, no tenderness. Okay, this time we're gonna do the range of motion in the knees. Since the patient don't have any bulges or any effusions in his knee, we're gonna proceed with the range of motion. So for the flexion, bend your knees or squat down on the floor. So I would know it, but you can just lift your leg. So extend, and then for the that's the flexion. Extension is to straighten his legs or squat up. When you squat, stand up. Yeah, try to squat and then stand up. Very good. That's the extension. So we're gonna do the internal and external rotation. So instruct the patient while sitting, swing the lower leg toward the midline. And then for the external other side. And then for external rotation is this what you did, swing the lower leg away from the midline. So this time we're going to do the abduction or the valgus stress test, medial collateral ligament with the patient supine and the knee slightly flexed. Move the thigh about 30 degrees laterally to the side of the table and place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. Valgus stress test. So this is it, right? So like this. So I will pull it with my right arm, holding it. So I'm pulling it towards me and pushing away the knee part. Okay. So, all right. Thank you. So this time we're gonna do the adduction. Similar to that, but instead of me pulling towards here, I'm gonna push it. So it's the reverse in my sense, right? Okay. This way. See? All right. Do you have any pain? Thank you. All right, this time we're gonna do the ACL or anterior drawer sign. So anterior cruciate ligament with the patient in supine, hips flex and knees flex to 90 degrees and feet flat on the table. Cup your hands around the knee with the thumbs on the medial and lateral joint and the fingers on the medial and lateral insertions of the hamstrings. Draw the tibia forward and observe it if it slides forward from under the femur. Compare the degree of forward movement with that with the opposite knee. So, okay, just like this. I hope you can see it. Okay, like I'm opening a drawer. All right, very good. So noted with few degrees of forward movement equally presented on the opposite side. Okay, this time we're going to check the posterior cruciate ligament or the PCL. So position the patient and place your hands in the position described from the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur. So instead of pulling, I'm going to push it. Okay, now can you just keep your hand and touch my skin region? Okay. Alright. Do you have any pain? Thank you. So this time we're going to examine the ankle and foot. So we're gonna do the ankle joint first and observe all the surfaces of the ankles and feet and palpate with the thumbs the interior aspects of each ankle. So I'm going to look at the feet, inspect it first. Okay, looks beautiful. I'm using my thumb anteriorly. Okay, have to palpate it. Both it. I'm going to look here. As now as it's seen in the camera. Very good. Okay, this time we're going to palpate the Achilles tendon to see if there's any tenderness. Okay, it's here on the other side. All right, no tenderness noted. Okay, and the heel, since the heel and the plantar fascia. Let's just see this one. Okay. Okay, the findings is no tenderness noted, noted with some bone spurs on the calcaneus. So that is the findings for the Achilles tendon and heel and plantar fascia. All right, so we're going to test the medial and lateral malleolus. Palpate for any tenderness over the medial and lateral ankle ligaments and in the medial lateral malleolus, especially in the cases of trauma. So, like this, so the lateral. You can palpate it on the side. All right. So no injury noted, and do you have any pain? No verbalization of pain. Okay, this time I'm gonna do the metatarsal phalangeal joint and the metatarsals in the groups because it's in the same area. So for metatarsal phalangeal joint, I'll palpate the MTP and compress the forefoot. So I'm gonna compress this to see if there's any tenderness. Okay, and exert pressure proximal to the heads of the first and fifth metatarsal. You see how I do it? can compress. His foot is a bit big and I have tiny hands. So the metatarsals palpate with the heads. See? Okay. In between and the groups between them with the thumbs and index finger. Okay, we're gonna do the range of motion of the ankle. So for the flexion, instruct the patient to point his foot toward the floor. Okay, how about that one? And then extension toward the ceiling. And then this one. Okay. Thank you. Alright, this time I'm going to demonstrate the ankle inversion and ankle eversion. So I'm going to instruct the patient to bend the heel inward and then he'll bend the heel outward. Okay. And then outward. Okay. Alright. And also check the toes. The finger. Alright. Do you have any pain? Any concern?
No.
Okay. Thank you. So findings, patient demonstrated good ankle foot range of motion without any difficulty. All right, we're going to touch base a little bit of the neuro because we already demonstrated this thoroughly last in the I think unit 6. So we're just gonna do the very basic for assessment of mental status. So I have to observe the appearance and behavior, speech, language, and mood, thoughts, and perceptions, and cognitive functions. So his appearance and behavior is really appropriate, and the way he speaks to me is in a moderate tone and a loud voice. And when he shakes his hand, is so gently, and he has respectful gestures. So I find the patient that is alert and oriented. He displays relaxed posture, no extra or involuntary movement noted. He is well dressed and well groomed, and the patient responded appropriately to all what we are talking about in all the discussion. And the patient is approachable and open to discuss any topics related to his well-being. So let's assess the mood. Okay, just briefly. So how is your mood today? I know you're tired.
Good, just tired.
Okay. Do you feel any depressed or discouraged in the past 2 weeks?
Nope.
Okay. And what do you see yourself in the future?
Retired.
That's gonna be tomorrow. Do you feel that life isn't worth living or you want to be dead? Have you ever had that thoughts?
No.
Oh, very good. Okay, how do you plan for future or for tomorrow?
How do I plan for tomorrow?
Yeah.
I don't. I'm just going to work in the morning, so I set my alarm.
Okay. And do you have any frustrations in life, like job, family?
Typical job stress.
Okay. Okay. So thought and perception. Okay, assess the logic and relevance, organization, and coherence of the patient. Patient's thought. So what can you advise? Again, I asked this in the previous video, but what can you ask or what can you advise to the young generation nowadays? Especially with what's going on in the world with the pandemic.
Yeah, people need to be aware and educated, and they need to follow the rules and be safe, but also be outspoken about what they believe.
Okay. So the patient demonstrated intact and of thought process. Thought contents are sensible, and the patient displays coherent and respectful throughout the conversation. Patient's perception displays appropriateness, and he provides a good life judgment and ideal life insights. So for the cognitive function, basic questions. Can you state your name and your family members and profession?
Jeffrey Downing. Family members are Ivy Downing, wife, son Randall Downing, daughter Rachel Downing. My profession is service delivery manager for a steel company.
Okay. What is the time now and place?
Riverview, Florida, 10:15.
Okay. PM. It's okay. So, explain to the patient that it's important to test the abilities to concentrate by asking to read a phrase in a book, which I'm just gonna, instead of the book, I'm just gonna ask you to read that in the wall. I'm gonna show it in the camera. It says,
Everything in love, 1 Corinthians 16:14.
thank you. So you,
Pass the eye exam too.
yes, do everything in love. So that's nice. So, okay, what is your birthday?
March 8, 1967.
All right, thank you so much. So patient demonstrate accurate attention and has intact memory and demonstrate excellent learning ability. Oh my God, this is our last video. Thank you so much, Dr. Jennifer Roberts. You are always in our prayers. And thank you so much for the being considerate. And this is really new, not whole, not all of the physical assessment that we've done in this term is new to me, but a lot in-depth assessment is really new to me, and I really appreciate all your corrections. I really appreciate your teachings, and I really appreciate your courage, because if I'm in your situation, I probably not can't do what you're doing right now. I admire you. Thank you so much, and we'll continue to pray for you. God bless.